Obviously, what I'm going to be presenting today is not epidemiological quality data. It's really a first look at the data that is available on the registry as of the beginning of May. We're also going to have a look at some even hotter off the press analysis of looking at the registry patients and what data is held on those patients by HES. I think it's nice to go back to the beginning of this journey that we've all been on over the last couple of years and look at what we felt were the important registry outcomes. Really, these were informed by the process of saying, if I wanted to try and get resources to improve the quality of my IBD service, what are the questions that I need to be able to demonstrate and answer? And simple things, numbers of patients, how many of these patients are being admitted to hospital, how long are they staying in hospital, surgical data, medication, and also cancer as well. You'll note that those questions cover probably about 90% of the actual cost of looking after IBD patients in the UK at the moment. So, the data I'm presenting from the registry is taken from 4 hospitals, and I think the leads from the 4 hospitals, Princess Alexandra, Barts, Luton Dunstable and UCLH, should be commended on the leadership that they have shown in generating this data, sometimes in really quite challenging circumstances. The 4 trusts are anonymized after some feedback from last year's registry presentation, and you can see that we've currently got about 4,240 patients in total on the registry at the moment. How does this split up? How does it look? And we had data on this on about 3,441, and you can see there's wide variation in the number of patients that are actually on the wide variation in terms of the numbers of patients that have been entered by the 4 trusts so far. It should be pointed out this does not represent in any way full case ascertainment for any of the sites involved. So a very simple question, what about smoking data? And there's a few things for us to learn as well. You can see that about 40% of our patients have never smoked, 25% are ex-smokers, and about 9.5% are current smokers. It's not been recorded in about 24% of patients, so therefore that's something that as a registry we need to explore and improve on moving forward. I think this slide last year caused huge consternation amongst a number of people, Dr. Johnson, and we've sort of looked at we're presenting the data here in terms of per trust. I think I was at a research meeting at lunchtime thinking actually if we had this data in our centres, it would be much easier to identify potential patients for research moving forward, particularly the patients who are on combination immunomodulator therapies and biologics. Again, this does not reflect current clinical practice in any of the trusts, but it gives you a flavour of the sorts of trends that can be observed in the using the registry data. I guess the controversial one is always going to be 5-SAs and Crohn's disease, and you can see quite major variations in the usage of 5-SAs and Crohn's disease between the different trusts. So, one of the key developments in the registry has been, and I think Richard Driscoll has been working has worked really hard in developing these links with HES and with HSCIC to get this data. This data is literally hot off the press. We got the slides on Monday. HES gave us a whole day of analyst time, which is virtually nothing, so it's probably as close to the back of a fag packet as HSCIC would admit to. I think there's a few really important themes that come out of this data. First of all, the linkage works in more than 99.9% of patients. Why is HES data important to clinicians? Well, actually, this is how hospitals in England get paid, and at the end of the day, it's how your salary gets paid. So HES data is really important for all of us. So looking at the the inpatient experience, there were over 4,000 inpatient admissions to the 4 organisations. There was 4,800 finished consultant episodes. About 1,800 of the patients were actually admitted to the 4 organisations in 2012, 2013. 28 patients had more than 10 admissions. I think that's a really interesting group of patients to look at and to find out why. And perhaps all of our hospitals are under huge pressures to reduce utilisation of emergency A&E and other emergency channels. And you can see that 919 of the admissions were via these emergency channels. In terms of outpatients attendances, the most common specialities were unsurprisingly gastroenterology. There may be a coding issue with general medicine. Perhaps maybe more of that is gastroenterology rather than general medicine. Pediatrics and general surgery are obviously feature prominently, and rheumatology, and I think others covers a whole hodgepodge of things. But I think the key thing is that I take out of this is actually patients are coming up to hospital maybe 5 times a year, 6 times a year on average. The next part of the slides is actually looking at the inpatient diagnostic coding, and this gives a broad feel of why patients are admitted to hospital. Most of these admissions that were coded were actually for endoscopic procedures. This just reflects the fact that we haven't had a chance to feed back to HSCIC the analysis and try and get them to drill down on it a little bit further. Obviously, other common reasons for admissions included administration of what's called cytokine. The next slide shows the inpatient length of stay. Again, this is important for hospitals. We're under pressure to reduce our length of stay. Again, the data that you might be able to see on the screen there shows that the majority of these were actually of 0 duration length of stay, which just reflects the endoscopy and the biologics administration admissions. Really, the next slide is on next steps and where really what the registry wants to achieve in the next year. I think one of our key objectives is to establish other means of entering data into the registry. Stuart has already alluded to that a major bit of work over the next year is going to be establishing a web-based data entry portal, which will bypass many of the challenges that we all face in our IT departments. So that will hopefully enable a lot more centres to participate in the registry and enter data. As part of the growing integration of registry and audit, we have integrated the biologics audit data set into the data entry portal as well as into the patient management system. So hopefully that will help improve case ascertainment in the biologics audit. In terms of participation in the registry, I think we'd like to be sitting here next year with presenting data from at least 25 centres and data on more than 35,000 patients. Whilst this in no way represents an epidemiological cohort, it's going to be a group of highly selected patients, it's starting to get to the point of being actually quite significant and meaningful in terms of a snapshot of a proportion of the IBD population in the UK and what's happening to them. I think we as an organisation need to try and make it as easy as possible for people to start to get the resources that they need to implement the registry and to contribute to the registry and the patient management system. I think it's important that we develop the experience, that we capture the experience of that centres have in implementing the PMS and contributing to the registry, so that can be used to support business cases moving forward. Other things is developing local reporting systems. And some of you may have seen the Paediatric Improved Care Now systems, which give really lovely graphs and outputs in terms of showing changes and improvement in clinical practice over time. I think that's something that we're very aware of as a major motivation. Pediatric participation I think needs to be a major focus for development over the next year, and trying to get a lot more kiddies onto the registry. Research has always been a major focus of the registry and a major outcome in terms of trying to facilitate research projects moving forward. Keith Bodger is going to be heading up the academic committee for the registry, which will look at proposals and see if we can facilitate them, and those will come hopefully from the academic community, but also from the pharma industry as well. The UK IBD Genetics Consortium is obviously very well recognised as a major player in IBD genetics and research in the UK, and we're very keen that we should develop that collaboration as a means of entering data for the Genetics Consortium at the point of patient care. And finally, perhaps some of the HES data that you may or may not have seen, there is a huge scope for developing research proposals through those links into HES data as well. So I think that's it. Thank you.